Good morning, and thank you for joining us for our conversation today. I'm CicelyWaters with the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. The FDA has issued emergency use authorizations for monoclonal antibody treatments for use in patients with mild to moderate COVID-19 who are at high risk of developing severe symptoms. We have Dr. Joneigh Khaldun, who is the Chief Medical Executive for the state of Michigan and Chief Deputy Director for Health in the Michigan Department of Health and Human Services. She's also a member of the White House COVID-19 Health Equity Task and has been the top medical advisor guiding Michigan's COVID-19 response. Thank you so much, Dr. Khaldun, for joining us today. Also here is Dr. Howard Haf, who serves as the Executive Director of the Maryland Primary CareProgram. During the COVID-19 pandemic, he has served as the medical planner for the Unified Command and lead on the Vulnerable Populations Task Force for the state of Maryland. Thank you so much, Dr. Haf, for your time today.
Pleasure.
So today we'd like to join and jump into a conversation and discuss how to improve equitable access to monoclonal antibody treatment. We all know that COVID-19 has truly exacerbated many inequities around the country, which is why healthcare providers have a responsibility to ensure that everyone has access to the treatments that they need. Both of your states have major initiatives to create access to monoclonal antibodies. Can you please describe your priorities in doing this and what informed your decision making? And Dr. Khaldun, I'll start with you, please.
Sure. Well, really excited to join this very important conversation and to talk a little bit about our experience in the state of Michigan. Michigan was actually early on in the spring, and dare I say winter of 2020, one of the hardest hit states by COVID-19. And we saw significant disparities actually play out. We were actually one of the first states to also track and announce the disparities we were seeing in infections and deaths. And I'll tell you, it was alarming what we saw. African Americans make up 14% of Michigan's population, but early on were 32% of infections and 40% of deaths. So that was with our initial surge in the spring of 2020. And so our priority for really emphasizing the importance and getting monoclonal antibody therapy out and accessible for our entire community was very simple. It was, we have to use everything in our toolbox to be able to fight COVID-19. When these monoclonal antibodies were first authorized, of course, we didn't have vaccines back in November. So for us to be able to really make sure our clinicians knew about the potential, the effectiveness, quite frankly, of these therapies, 70% reduction based on clinical trials in hospitalizations and deaths, that's a big deal. And when we were, particularly last spring and in our fall surge, seeing our hospitals become overwhelmed, particularly seeing more Black and Brown people being hospitalized, there was no question that we had to make sure this was available to people, but also really focusing on that equity lens, which we have done throughout our entire COVID-19 pandemic response in the state.
Thanks so much, Dr. Khaldun. And Dr. Haft, same question. Can you describe some of your priorities in making monoclonal antibodies more accessible to the people in Maryland, and what informed your decision making?
Yes, certainly. And it's the fundamental question. I think that faces all of us, as you pointed out, abundant, and we've seen abundantly and play out throughout this pandemic, that it's really shined a bright light on healthcare disparities. And much the same as what happened in Michigan, we noted very early on that we're seeing higher impacts in communities of color related to hospitalizations, related to deaths, related to access to testing, which was less available to them. And then in the fall, when monoclonal antibody EUA was first released, we were primed and ready to include this as now the new therapy, the one and only therapy for symptomatic individuals in the community who did not yet need hospitalization, and one that we could shorten their illness, prevent them from becoming hospitalized, and prevent deaths.
Dr. Haft, Can you speak a little bit about what some of the most significant barriers to monoclonal antibody treatment were in Maryland? And did you focus on equitable access for particular populations like rural, urban communities of color, or low income individuals in your strategic plan to promote access?
Again, that's a great question, and the answer is absolutely yes. Right from the very beginning, we focused on how to deliver monoclonal antibody therapy to everyone in the state who might be in need of that. And we started, in the very first week by saying the state is very diverse, not only in its racial and ethnic composition, but part of it is rural, part of it is suburban, part of it is very deeply urban. And we needed to make sure that we could address access in all of those areas. And the data shows where we see communities that have high incidence of hospitalization and high incidence of positivity and high incidence of death from COVID. We need to make sure we plant abilities to deliver monoclonal antibodies to the individuals in those communities, either by having a physical plant that could infuse individuals or by developing transportation systems to bring those individuals to the sites where transportation was an issue, as it sometimes is in the cities.
And Dr. Khaldun, we'd certainly love to hear about what some of the most significant barriers were in Michigan to monoclonal antibody treatment and how you focused your strategy and if you focused your strategy on particular populations.
We found that some of our health systems had a centralized process. So literally there would be a team of nurses, clinicians, volunteers who would scan through all of the positive tests for a particular health system and then call those individuals back who had already been prepped by the clinician who gave them their diagnosis. They would call those patients back and say, hey, did you know that you qualify for monoclonal antibodies? Let's go ahead and get you in. So we did that. One thing we also did was actually integrate this into our case investigation process. So we actually had part of our case investigation and contact tracing process actually automated a little bit, at least the initial component in Michigan. So we would actually make sure that patients, when they got a ping, if you will, about a positive test, that we also incorporated the fact that monoclonal antibody therapy was accessible for them. And when our case investigators literally called patients to talk to them about their positive test, we included information about monoclonal antibody therapy in that conversation. And we also brought monoclonal antibody therapy to patients' homes. So we actually have right now across the state EMS providers who are literally going to patients' homes and administering it to them in their homes. And I think really when you talk about access, you have to talk about removing barriers and meeting people where they are. That's really where the best public health happens. And so again, similar to what Dr. Haf mentioned, we've been really focused on equity and removing barriers to access.
Yeah, absolutely. And given all of the work, Dr. Khaldun, that you all have done in Michigan in terms of making monoclonal antibodies more accessible to vulnerable populations, what are some of the lessons learned that you could share with other states, other healthcare providers, or other healthcare systems and their stakeholders about addressing some of the barriers that you all came across?
Equity will not happen, access will not happen unless you are actively thinking about it, putting resources and strategies towards making things happen. So again, data, we actually have a process where clinicians, clinics give back to us what they're doing as far as not just they've ordered the monoclonal antibody therapy, but actually who they're administering it to. We've got it actually broken down by demographics. We actually have mapped out across the state. Michigan has 10 million people, very large, diverse state. Very, very rural areas. We have the Upper Peninsula. We also have, of course, the metropolitan Detroit area. We have the city of Detroit, that's the largest and unfortunately the poorest majority African-American city in the entire country. So when you do public health in Michigan, you have to be intentional. You have to think about the various communities. Early on, we saw a disparity where African Americans, even though we knew they had the higher hospitalization rates, they weren't actually receiving the monoclonal antibody therapy in the rate that they should from an equitable standpoint. Very targeted outreach to those health systems in that area to support them in getting those operations up and going. And similarly, we saw issues with access in our rural areas. So found out who those health systems were, talked to them one-on-one, and just did the work. And we now have expanded access. Some of those disparities have certainly decreased. And so that's, you just have to be very, very, very intentional.
Wonderful. And Dr. Haft, any lessons learned from Maryland that you'd like to share with other healthcare providers or other stakeholders who may be watching?
Sure, I'd be delighted to do so. In Maryland, we've been fortunate in having CRISP, the State Designated Health Information Exchange, as a really shining example of how that should be done. So we can look at the data every day and see what percentage of patients that we have infused that are African American, how many are Latinx, by community, by hotspotting around the state. And that is just so important. Another lesson is testing is really critical. The lessons learned is to make sure that even though that you're not only your monoclonal antibody infusion opportunities are available, but testing opportunities are available. And primary care was a wonderful resource for that. We provided them free of charge as many point of care tests as they wanted, and said, this is for the express purpose of diagnosing individuals who are symptomatic and eligible for monoclonal antibody therapy. And then making sure that there is a simple and understandable referral system for anyone who wants to send a patient to any monoclonal antibody therapy site. And there we leaned on our state HIE again, who were able to put together an online referral system that many people use. But we also said, let's just not stop there. Let's make any kind of referral that anyone wants to make. Some people are comfortable with doing faxes, some are better with emails, some love the online referral system. Let's be eclectic, and just as we try to meet our patients where they are, let's try and meet our providers where they are.
Absolutely. And both of you have stressed and highlighted the importance of testing in this entire process. Could you both talk about what has made the biggest impact in terms of closing that testing to treatment gap in your states? And starting first with you, Dr. Khaldun, what has helped the most in Michigan in terms of helping to close that testing to treatment gap?
Absolutely. And I agree wholeheartedly with Dr. Haft, especially early on, access to testing was just so limited. We actually, in Michigan, implemented very early on neighborhood-based testing. So testing everywhere, partnering with community-based organizations, places of faith, really, and actually targeted those testing sites based on literally by census tract where they ranked on the social vulnerability index, which is one of the tools that we use to identify where some of the most vulnerable individuals in the state were. Not a surprise, in areas where there were higher social vulnerability index, that's also where we saw higher rates of infection and death. So we targeted our testing in that way. We made it free and accessible for everyone, which was really, really important. Communication efforts with people in the community. Everyone didn't want to hear from me or the governor, but they may have had a trusted community member that they wanted to hear the message from. So we actually lifted up those individuals to do the press conferences and town halls and whatever else to really get the message out about testing, treatment, and vaccines.
And Dr. Haft, can you share what has been most effective in Maryland in terms of closing that testing to treatment gap?
The gap is best bridged, I think, by the connection from as soon as a test is done, being able to counsel with that patient and say, you are eligible. It's best being counseled from a trusted counselor like a primary care provider or other provider. But whoever is giving that information, being able to connect it as quickly as possible, the positive test together with the need and the appropriate availability of monoclonal antibodies. Or that person didn't have a primary care provider, they provided them with an online consultation service that could evaluate them. If they didn't have web access, they get a telephone number of someone who could do a telephone interview and evaluate them in terms of their availability or their eligibility for monoclonal antibodies. So it was making sure, again, bridging all of those gaps so that there's no one left who would test positive, who would not be able to get as soon as possible information about their eligibility and the value of monoclonal antibodies for them.
Shifting a little bit to talk about the emergency use authorizations for these monoclonal antibodies. Back in May, the FDA updated the emergency use authorizations for the monoclonal antibodies, and now healthcare providers have a little bit more latitude to determine which patients are deemed high risk or defined as high risk, and which patients are eligible for the monoclonal antibody treatments. Given this new expanded emergency use authorization from the FDA back in May, how has the expanded FDA emergency use authorization impacted the work in your states? And Dr. Haf, start with you in terms of how that's impacted your work in Maryland.
It's been an answer to the questions that we've heard consistently from providers about unique cases that seem to really fit well and have a need for monoclonal antibodies, but not fit exactly into the very specific characterization in the EUA. This helps with that. It gives the clinician the ability to capture all of those cases that, before they may or may not have captured because of their concerns about whether it fits neatly into the EUA. There are still people across the state who will benefit from monoclonal antibodies. And now this liberalization of the indications will help capture more of those patients. And that's a good thing.
Thank you for that. And Dr. Khaldun, how has this impacted your efforts in Michigan?
Absolutely. So, it's been really important. Similar to what Dr. Haf said, I would speak to health system leaders, individual clinicians who were excited. They wanted to provide monoclonal antibody therapy to their patients, but they were actually confused when they read all the details of the EUA. They said, "Oh, this person doesn't meet clinical criteria based on the EUA." So it certainly has opened that up. And again, particularly with our Black and Brown communities who have been at higher risk of severe COVID-19 progression of their disease and death. This absolutely allows clinicians to understand that context. I think we still have to study reasons. We, of course, know about social determinants of health and inequities, but the fact that a lot of Black and Brown people, not because of skin color, but because of those social determinants of health, are more likely to have underlying medical conditions. Perhaps they don't have access to early health care. Some of them often may not be as likely to have a usual source of medical care. So to be able to have this available and to have clinicians be able to use their discretion, I think is really, really important when it comes to addressing equity.
The FDA recently updated the emergency use authorization fact sheet to include guidelines for subcutaneous injection administration of monoclonal antibodies. How do you foresee this will impact how clinicians counsel and treat high-risk COVID-19 patients, and how could it impact the effort to promote access and address disparities? And Dr. Haft, I'll turn to you first for your thoughts on this.
Yeah, I think it opens up another opportunity for treatment and will help to address equity issues and that it can be delivered more rapidly, more easily at locations that it can be brought to patients rather than patients having to go to some site to be infused. And I think as the science evolves, we may find that it's becomes more of a standard approach. I think the time will tell whether it becomes more of a standard approach or not. But right now, it certainly is and makes equitable access easier in certain circumstances.
And Dr. Khaldun, the same question.
I would say it's really important in expanding access. There may be sites where there's not someone available who knows how to place an IV and to be able to mix it in and run it in. So this is something, subcutaneous is something that's a little more simple, that often people, even in local health departments, the staff are more likely to be able to do something subcutaneous than they are to be able to start and run an IV. So I think it certainly does help when it comes to expanding access, bringing it into the community, as Dr. Haf said, and not necessarily needing that additional skill set from a clinician standpoint when it comes to how it's administered.
Thank you for that. I'd like to talk a little bit about the connection between vaccines and the monoclonal antibody therapies. As our vital nationwide effort to vaccinate people continues, what role will monoclonal antibodies play? And really, why is access to treatment still so important for vulnerable populations who have been disproportionately impacted by COVID-19? If we see the rates for vaccinations continue to increase, why do we still care about access to monoclonal antibody therapies? And Dr. Haft, I'll turn to you first, please, for your thoughts on that.
Sure. I think the reality is that even as we increase vaccinations, and we fully intend to do that, that there will still be a residual number of people who are not vaccinated, who are susceptible to COVID-19, and would benefit if they become ill with COVID-19 from monoclonal antibody therapy. So that's not going to go away. It's going to be smaller in proportion, but it probably will also, as Dr. Khaldun had suggested, it probably will accentuate the disparities. And we'll see more of the individuals in that category who did not get vaccinated in the Latinx or in the African American communities. So we need to preserve this ability. Vaccines, as I think we probably lost a little bit of track, don't necessarily prevent you from getting COVID. They reduce the likelihood of hospitalization and death, but even hospitalization reduces the likelihood. But we know that people will still get hospitalized after they're vaccinated when they get COVID. It's not large numbers. It's in fact very small numbers. But those individuals also would benefit from monoclonal antibody therapy.
When the monoclonal antibody first received emergency use authorization back in November of 2020, we did see and experience some hesitation from both healthcare providers and patients. Are you continuing to experience providers or patients who are reluctant to get vaccinated or receive monoclonal antibody treatments? And if so, how are you dealing with that today?
Yes, this concept of, we call it hesitancy, but I think it's just, people just have questions and concerns about their bodies and what potential therapeutics or medications are being placed in their bodies. So we have understood this to be a challenge. We knew it was going to be a challenge before the vaccines were even rolled out, and started thinking about that and doing research and surveys with our people or the public as far as their attitudes and behaviors when it came to therapeutics and vaccines. We've made some progress. We've certainly made some progress with more and more, I think, as people's family members and friends have gotten the vaccine or gotten therapeutics and they've heard about it, they're quite frankly more inclined to want to get it themselves. Some people very early on said, I don't want to be the first one. So they wanted to see how it rolled out. And as it has, they've been able to do that. We spent a lot of time, again, especially early on, in our southeastern Michigan community. Again, early on, that's where our bulk of our cases and deaths, unfortunately, were. So a lot of efforts when it comes to communications. We continue that. We have a bipartisan, we call it the Protect Michigan Commission, but a bipartisan commission that's sole focus is to talk about vaccines and hesitancy and making sure we're getting that message out into communities. So we're making some progress, but as Dr. Haft said, we still have a ways to go. We still have communities. Unfortunately, the coverage rates for African Americans, Latinx, when it comes to vaccines is still lower than what we would want. We still have a decent proportion of our healthcare workers, including people who work in skilled nursing facilities, who don't want to get vaccinated. So I think it's just public health messaging, working with trusted community members, and not giving up. I know a lot of our public health staff and leaders are tired, and they keep saying, just get it. We want you to live. We want you to get these therapeutics, get your vaccine. We can't give up. Public health communication is very hard, and we just have to kind of continue right now and not give up. I think we'll continue to see our vaccination rates and our utilization of therapeutics increase.
Thanks so much. And Dr. Haft, are you still experiencing any of those types of hesitations from either healthcare providers or patients in terms of the monoclonal antibody therapies?
Yeah, it's better now than it has been, incrementally better, but it's far from perfect. We leaned heavily on our providers in the same way we asked them to have these, empathetic conversations with their patients, to meet them where they are, and discuss the value of vaccines, to have the same kinds of discussions when it was appropriate about monoclonal antibody therapy. But we still have a long way to go. Now, so I would add also that a lot of the hesitancy we saw in particularly in the African American community, was very well-deserved criticism of how that community was treated in the past by the healthcare system, with the Tuskegee experiments, with other kinds of lack of inclusion in previous vaccine or monoclonal antibody studies, and other things that I think we had to acknowledge, yes, that those things are true. We do own those things, but this is a different time. And now we want to understand what you're feeling and where you are now, because this is important.
Thank you both so much for that. And for joining us today as well. We've covered quite a wide range of topics today regarding monoclonal antibody therapeutics, from eligibility to access to best practices. Thank you guys so much for sharing what you've done both in Maryland and Michigan. But I ask you, if there is one thing that you'd like for those listening to walk away with in terms of monoclonal antibody therapeutics, Dr. Khaldun, what would that be?
I think particularly for the clinicians, I think you have to meet people where they are, and making it as easy for people to obtain it. So we talked about bringing it to the nursing home. We have a homebound strategy. I think also logistically, just making it very centralized and simple for clinicians as well is really important. Just meet people, whether it's a clinician or someone who's infected, meet them where they are.
Thank you so much. And Dr. Haft, for the viewing audience today, what's the one thing regarding COVID-19 monoclonal antibody therapeutics that you'd want them to walk away with from this conversation today?
I like people to understand that it's a new therapy and unique in many ways. And for us to be effective in delivering that therapy, we need to be all inclusive in terms of our providers, in terms of the people that we serve, in education, in access, and in understanding where they are in terms of this particular therapy, or anyone that comes down the pike in the future. I think that we're in a rapid cycle of development of both new diseases. New pandemics are occurring, more epidemics are occurring in the last 200 years than occurred in the 2,000 years before that. But we also have the evolution of new therapeutics in science. It's going to take a lot of understanding to keep the public well aware of what the value propositions are for therapeutics and what we need to do as a society to respond to the future threats of all kinds.
Thank you both so much for the final words. And thank you once again, Dr. Khaldun, Dr. Haft, for taking the time to talk with us today. I know that your schedules are extremely busy, but we also know that the topic of monoclonal antibodies is an important one. So thank you so much for taking the time to speak with our audience.
Thank you. It was a great conversation. Good to see you, Dr. Haft.
It was a pleasure. Dr. Khaldun, it's good to see you again, too.
And I'd also like to thank all of those who joined us via live stream. We hope this conversation has provided helpful information, and we encourage you to visit combatcovid.hhs.gov to learn more. And you can also call our COVID-19 call center. For English, 1-877-332-6585, or Spanish, 1-877-332-6585. 366-0310 to find a COVID-19 monoclonal antibody treatment site near you. Thank you all again for joining us for today's conversation.